flow of event will be, I will be introducing the today's session, and I'll invite Dr. Neeraj to give the opening remarks, and then I'll invite you so that you can start with your first talk.
Thank you very much. And will I be able to share my slides? Let me try that it works.
Yeah, you can start.
Yes, perfect.
Dr. Vikram, we are live now.
Yeah. Dr. Ilmis is trying to share her slides.
Please start.
Dr. Ilmis, are you trying to share your slides, or shall we start?
You can start. I have tried sharing it. It works.
Okay, thank you.
Thank you.
So, good evening, everyone, and good morning to all our international faculty. On behalf of IAP Allergy chapter, I welcome you all for this academic feast. It's a great pleasure to welcome you all to this special webinar in observation of World Asthma Day. We are honored to have a distinguished panel of international experts joining us today to share their insights, experiences, and latest advances in asthma care and research. This session is particularly valuable for all our colleagues across India, as it provides a unique opportunity to learn from global best practices, explore evolving management strategies, and understand how emerging evidence can be applied in our local healthcare settings. With asthma continuing to be a significant public health challenge in India, today's discussions are aimed at strengthening clinical approaches, improving patient outcomes, and fostering international collaboration in respiratory care. Thank you for being part of this global dialogue as we walk together towards better breathing for all. To begin, let me invite Dr. Neeraj Gupta, who is chairperson of IAP Allergy and Applied Immunology chapter.
Thank you,
Dr. Gupta. Yeah.
Thank you, Dr. Vikram, for the nice introduction to the webinar. And as we all know that from IAP Allergy and Applied Immunology chapter, we are trying to bring whatever the best in the specialty across the globe. And today is a very important day as we are celebrating World Asthma Day. Today also, GINA, which is considered as like the Bible body, has released another edition of, you can say, like asthma care guidelines, which are considered to be, you can say, like the pinnacle for asthma management for everyone across the globe. So we are very fortunate today that we have our guests across different countries today to share their thoughts. And I am very thankful to them on behalf of IAP Allergy and Applied Immunology chapter. So we can start with a historical session, Dr. Vikram.
Yeah, thank you, Dr. Neeraj Gupta. So let us, without any ado, we will start the first session by Professor Oj Ilmes. She is from Turkey. She is chair of pediatrics at Manisa Chalal Behar University and a key figure in ATS global programs. She is chair of the MECOR ATS program, and she is co-chair of the VIPPN ATS. She will speak on small airways and asthma. We welcome you, Professor Oj Ilmaz.
Thank you very much for this nice introduction and invitation to this international program. I will be talking about small airways in pediatric asthma because this forms a significant component of our problematic control, children having problems in asthma control. I will be talking about why we are talking about small airways, what are the anatomical and physiological differences from other parts of the lungs, asthma and small airways, treatment option considering small airways, and therapy resistance in small airways. When we look at the small airways are components of the airways that are less than 2 millimeters in diameter, and they lack cartilage on walls, and they consist of the distal parts of the airways, like alveolar canals, respiratory bronchioles, etc. When we look at the anatomy of this part of the airways, looking at this is a left lung bronchogram, you can see that each region of the lung shows different branching pattern, and number of branches from the main bronchus to gas exchange areas changes in different parts. And total cross-sectional area increases as we move to the small airways, making this component of the airways significantly important in considering for diagnosis, asthma pathophysiology, and treatment. So when we look at the physiology of this part of the airways, we see that the bulk air transport is due to the pressure gradient formed by the respiratory muscles in proximal parts. However, gas diffusion is due to concentration gradient, which makes the pressure gradient less. Therefore, proximal airways are more prone to precipitation of small particles, therefore predisposing this part of the airways, one, to the detrimental effect of the small airways exposed from the environment, two, deposition of small particles with treatment. So in the healthy airways, resistance in airflow in bronchial wall decrease as we move from large airways to small airways. Because as we have just said in the beginning of our talk, this part lacks muscle mass and cartilage. However, in asthma, there is mucosal inflammation in all the bronchi, and resistance, instead of decreasing, increases to higher extent as we move to the smaller airways because of the diameter, small diameter, as we all know, as inflammation and bronchial airway wall edema increases, the percent change in the airway area increases more. Therefore, we call small airways the quiet zone in asthma because it's difficult to measure the changes in these airways. What happens in our small airways in asthma? Well, with inflammation, we have goblet cell metaplasia and increased mucus production, epithelial desquamation, reticular basement membrane thickening, muscle hyperplasia and hypertrophy, and one of the most important parts of the pathophysiology, extracellular matrix remodeling. So inflammation leads to plasticity in airway innervation, and this leads to hyperactivity. So it's not only the airway and anatomical changes in the airway wall in small airways, but it's also innervation changes leading to hyperactivity. Moreover, there is eosinophilic infiltration in proximal airways, and interleukin-5 expression increases more in small airways, and we will be coming back to this when we are talking about different therapeutic options. So we said small airways are the quiet zone because it's hard to measure the changes in these parts, but they're also important as a treatable trait. We all know that one of the most important reasons for not achieving asthma control in children is using treatment that is not in compliance with the phenotype or endotype. So current concept of individualized treatment requires addressing the treatable personal traits rather than following the same guideline steps for everyone. So now the guidelines also suggest that, or advocate for delineating the phenotype, endotype of asthma in adults and physicians before we start our treatment. So why the small airways are considered a treatable trait? Because the changes in small airways are related to airflow limitation, as we have just mentioned. Because of the innervation changes, there is airflow hyperreactivity, and there is an increase in inflammation in small airway trait. Which phenotypes are associated with small airways? So we need to consider small airways as a potential target for our treatment in these patients. Well, if the patient has frequent exacerbations despite normal spirometry, because small airways are not usually measurable, small airway changes are not usually measurable with spirometry. Children with obese asthma, where small airways are involved more. Asthma in tobacco users, nocturnal asthma patients with nocturnal increase in their symptoms. Th2 type asthma, exercise-induced asthma, and increased patients who show increased bronchial hyperreactivity are may be considered as having small airway treatable trait. When we look at the spirometry, I said that spirometry is not a very good measurement tool for measuring small airways. Well, maximum mid-expiratory flow 2075 has been shown to be a marker of small airways to some extent. However, these measurements are very variable and they are vital capacity dependent. Therefore, we say that spirometry is not a very good measure for small airways. Oscillometry is the new tool that is quite promising to show the changes in small airways. By looking at the resistance and reactance values, especially R5 and minus R20 is associated with small airway obstruction. This is an example from one of the patients' impulse oscillometry results in our clinic with small airway phenotype. And FeNO, we know that nitric oxide measurements are associated with alveolar inhomogeneities and small airway phenotype. Is it associated with asthma control? It has been shown that spirometry does not show much difference in well-controlled and uncontrolled asthma patients. However, when we look at the small airway measurements indicated by change in R5 minus R20 values in impulse oscillometry, there's a significant difference indicating small airway involvement is quite prominent in uncontrolled asthma. And it has been shown that correlation of abnormalities in oscillometry, as you can see in this paper by Yoon et al. Published in 2023, correlation of abnormalities in oscillometry and FeNO exist with uncontrolled asthma. So how do we interpret oscillometry findings in pediatric asthma? Well, if we have uncontrolled asthma in a child, let me use my laser pointer. If we have uncontrolled asthma in a child, first we need to confirm the asthma diagnosis. This is very important, and not only clinical symptom-based diagnosis, but also objective diagnosis based on bronchodilator response, bronchoprovocation, PEF variability, or nitric oxide measurements. Well, if the asthma is confirmed, then we check for inhaler technique. If there's no problem in the inhaler technique, then we continue to do phenotyping to confirm that this is a Th2 high asthma, and we address for comorbidities. If the symptoms are uncontrolled, if the patient has Th2 high phenotype, then we check medication adherence. If the patient is adherent to the medication, then we go ahead to evaluate for small airway involvement in these patients by oscillometry. If the oscillometry is normal, then we consider increasing the ICS dose, inhaled corticosteroid dose, or add-on therapies. If the oscillometry indicates or suggests, because we know that this is a promising measure, but we do need to have more research. If the oscillometry indicates small airway disease, then we can consider again increasing ICS dose or switching to extra fine inhaler therapy, because we need finer particles to reach to the small airways, or biologic targeting in interleukin-13 pathway, and we repeat oscillometry to measure for small airway disease in these children in 1 or 2 months. Well, if the oscillometry shows proximal obstruction, then we interpret with spirometry findings. And we will be talking more about spirometry with Dr. Gochikoa. What is the role of asthma treatment? What is the role of small airways in asthma treatment? Well, we need to see that small airway involvement is associated with asthma control, quality of life, and exacerbation frequency, as I have told in previous slides. And these need to be assessed for evaluation of treatment efficacy and to guide aerosol management. It has been shown that for small airway involvement, aerosols with a smaller diameter measures reach peripheral airways and small airways to a more great extent. This is a paper published some time ago showing the mass balance and regional lung distribution comparing to the particle diameters, and penetration index for small particles is higher. They penetrate lung periphery more. So if we are considering small airway, predominantly small airway phenotype, endotype in a child, then we may think about changing to a small particle inhaler for these children. But not only the particle diameter, but also the device and flow rate changes the small airway deposition in these children. So it's not only the molecule that these children are using, but we need to consider the device and the technique they are using this. This is another paper published in 2021 by Watts et al. Showing differential deposition of inhaled treatments in the airways. It has been shown that with some of the biologic treatments, there is a change in small airway involvement, especially considering that small airway involvement is predominant in Th2 type inflammation. So especially with omalizumab treatment, there is a change in small airway inflammation in these children, and biologic response to biologics treatments with biologics like omalizumab is better in children with R5 minus R20 values consistent with small airway involvement in children. So these are different, and these biological response to these treatment are also reflected in oral corticosteroid requirement and asthma control. Final slide about allergen immunotherapy. It has been shown that in children with uncontrolled asthma, with predominant small airway involvement, allergen immunotherapy may provide improvement in symptoms to some extent, but usually it's not significant in the long term. So take-home messages from my speeches. Small airways form the silent region in asthma, and they are difficult to evaluate with conventional methods. However, forced isolation techniques are promising for evaluation. And small airway involvement needs to be considered in selected patients with uncontrolled asthma. It is important to evaluate for biologic treatment, inhaled corticosteroid treatment, both particle type and technique. However, there are still problems in evaluation of the silent zone, and we still need some work for comprehensive evaluation of treatment response in these children. Thank you for your attention.
Thank you, Professor Ilmas, for discussing the intricacies in the managing small airway disease in children. Went through from the pathophysiology to the management part. Thank you very much for the insight you have given. So now we move on to our next session. We'll walk us through the lung function algorithm for asthma diagnosis. We discussed about the clinical aspects by Professor Ilmas. Now we will be moving to the lung function algorithm. providing clarity on its implementation in various clinical settings, and we'll discuss its implication for patient outcomes. We are honored to have with us Professor Laura Gochico, who is an expert from European and ATS task forces. She's from Mexico, and she's considered to be an authority in lung function. We are pleasure to have you over here, ma'am. And she will bring extensive experience and insights into this topic. Her expertise will help us translate this algorithm into our daily practice with confidence and precision for sure. Welcome, Professor Laura.
Okay, can you hear me there?
Yeah, we can hear you.
Oh, thank you very much. Thank you, Oji, for this small airway disease conference. I really like the oscillometry, but I'm not going to talk about oscillometry. I'm going to make an introduction for our next conference. So I just want to remember you about how is the algorithm to get to the diagnosis of asthma or something else. This is my conflict of interest. This is a figure that I love to show in every talk, just to put in the context when we have a specific disease, what are or which are the tests we need to look at. So right now, what I am going to talk a little bit more is to remember how we interpret spirometry in order to get the diagnosis for asthma. So this is a typical spirometry. So you need to have the flow volume graph, the volume time graph, and all the results that you need to make, to see that it is a good spirometry and also to interpret the spirometry. As you can remember, we need to have some acceptability criteria in the flow volume graph. You need to have this abrupt and vertical start. Then you need this peak flow at this triangular shape. And then you have the inhale curve over here. And in the volume time graph, you need to have this back extrapolated volume that should be less than 100 millimeters. You have to see this knee and then the plateau that has to be more than 1 second at the end of the exhalation. And when you have these 3 acceptable maneuvers, you need to check for the repetibility. So the difference between the 2 highest FEVCs should be less than 150 millimeters, and the difference between the 2 highest FEV1 should be less than 150 millimeters. So in this case, you can see that we have all these acceptability and repetibility criteria in the pre- and post-bronchodilator test. So for the interpretation, once that you have this spirometry that is acceptable and repeatably, you need to see the first thing that we need to check is the coefficient FEV1 over FEVC. And we need to see if this is above or below the lower limit of normality. Just to remember, the lower limit of normality is the same as the percentile 5. This means that in the Gaussian curve, those that are below of minus 1.64 standard deviations or C-scores, these ones are, it doesn't mean that they are abnormal, but it means that the results is in an extreme, so we need to check. So when you hear about lower limit of normality, that is the same that's saying that is below 1.64 standard deviations or C-score, or that is below the percentile 5. So that is the lower limit of normality. So if you find that the FEV1, the FEVC, or the coefficient are below this lower limit of normality, then you have to pay attention. So in this algorithm, it says that if you have this coefficient is not above the lower limit of normality, then you have to check for the FEBC. If the FEBC is normal, then you have airway obstruction. If not, it's possible a mixed disorder, and then you need to measure lung volumes. But if the coefficient is above the lower limit of normality, then you check the FEBC. And then if that is normal, you are going to have a normal spirometry. If not, it's a possible restriction, and then you need to measure complete lung volumes. But we used to say that it doesn't matter if it is a normal spirometry in basal conditions, or if the patient has airway obstruction. All the time, please ask for the bronchodilation test. It doesn't matter if it is normal, but because sometimes the patient has symptoms and the bronchodilation is positive, and then you have the diagnosis there of asthma in the case you are thinking of that. So for the bronchodilation, you need that the FEV1 or FEBC increase more than 10% from the predicted. And if that is positive, then there is a response to the bronchodilator, and then you have to interpret again the post-bronchodilator spirometry. But there are patients that even though you are thinking in asthma and they present airflow airway obstruction, the bronchodilation test is negative. So in this case, in this patient, what we are having is a normal baseline spirometry with no response to bronchodilation. If you can see, the percent of change is below 10% in FEBC and FEB1, so that's why we are interpreting the spirometry with no response, and you have a normal spirometry, so what is going to be the diagnosis? So in these cases, don't forget to make a bronchial challenge test, because remember that if the clinical situation of the patient is that you are thinking that that is asthma, even though you have a normal spirometry without a bronchodilator response, you need this bronchial challenge test. Remember that we have indirect and direct bronchial challenge tests. I am not going to talk about them, but please remember that the direct is when we put some metacolin to inhale for the patient, and directly you are going to have a narrowing of the airway. And the indirect is when you use any of these other mechanisms, but in the final thing is that you are looking for this narrowing of the airway. In that case, if that is positive, then you have the diagnosis. And that will tell you that that airway has some kind of instability, and then you will have the asthma diagnosis. But what happens if the bronchial challenge test is negative? Well, in that case, you need to look for some differential diagnosis. And these are some of the differential diagnoses that you can have. And this is the introduction to lead Dr. Todd Olin to talk a little bit more about this differential diagnosis. Thank you very much.
Thank you, Professor Laura, for bringing us the details about the spirometry, and definitely using it, making it objective, will be improving our diagnosis and preventing misdiagnosis also. Thank you very much. Next, we have as a clinician, we often encounter patients, especially young athletes and adolescents, who report to us with shortness of breath during playing or during exercise. While asthma is frequently which comes to our mind, not all these cases respond to typical asthma treatments. So this raises the need to look beyond asthma and consider other differential diagnoses. So one of the most significant diagnoses being exercise-induced laryngeal obstruction, or what we call it as EILO. So we are fortunate to have with us Professor Todd Olin from USA, who is considered a leading expert in the field, who will guide us through the nuances of recognizing and managing EILO in our clinical practice. So welcome, Professor Todd Olin. Has he joined?
I think Professor Todd is about to join us. So what we can do, we can probably utilize some time to discuss some of the questions from the previous sessions.
Yeah,
so one of the question which
that's a
I
good
would
idea.
like to ask directly from Professor Yilmaz as well as Laura. So Laura is a very good friend, and thank you very much, Laura, for joining us and arranging all these this fabulous webinar for us and the fantastic speakers. Thank you very much. So one question which was always in my mind, though you have tried to answer it on the group also, regarding the oscillometry. So oscillometry is considered to be, you can say, like a very sensitive tool, especially for the small airways. And in pediatric age group, where the practical difficulty of spirometry is definitely there. We being pediatricians, we always face this difficulty that they are not able to do spirometry. And then there are special groups in which neuromuscular disorders and all those things are there. So at our center also, we are doing oscillometry regularly now for past 7-8 years. It is a very useful tool. So just wanted to ask your opinion that where is the, you can say, like the hitch, or there is some hesitation in involving oscillometry, such a useful tool, in the GINA guidelines or so, though you have just shared that, okay, 1 or 2 lines have been mentioned about oscillometry. Is it only the standardization of the machine, or it is something else which is, you can say, like stopping world authorities to involve oscillometry in the algorithm along with spirometry?
Ozzy, you want to respond? Well, what I think about it, well, here in Mexico, there are several doctors that they are asking for both tests, for spirometry and oscillometry, because sometimes, because we used to think that oscillometry is for those that cannot do the spirometry, but that is not true. As Dr. Ozzy said, I think we, in the future, probably in the algorithm is going to be the oscillometry. But the problem now is that there are several gaps about oscillometry that I mean, it's not very standard. It's different if the device is different, if the reference values, which variables you are going to take to interpret. So that's why I think in some of these guidelines or initiatives is not in the algorithm. But the good news is that it's there. Now we are talking about that. In CEPAR, from the Spanish, they are also having the oscillometry in their guidelines. So yes, I think that. I don't know, Ozzy, what do you think?
I would be telling the same thing. There has been a problem of standardization due to different devices, and we did not have normal values from various populations. Thanks to authors like Laura, who has done lots of work on impulse oscillometry normals in both in children and adults, I know that GLI is working on getting a new standardized measurements for iOS values to impulse oscillometry and resistance values. And I think that is the major obstacle that prevented until now of incorporating iOS into guidelines. I think in the near future we will have, with standardization, especially with getting these values in GLI measurements, it will be used soon.
So 2 more questions which I was having. The other question is that, like, we understand that spirometry can be, you can say, like normal in a symptomatic patient, and it is probably less sensitive for the small airway as compared to oscillometry, and oscillometry can pick up those which are not picked up in the spirometry. Can vice versa be already true? That means, like, oscillometry can be normal and spirometry can pick up something. Is it possible theoretically or practically?
Theoretically, I don't think so, because resistance measurements in impulse oscillometry provides more information. But as Laura has just said, because of the technical problems and standardization issues, it is hard to interpret impulse oscillometry compared to spirometry because it's so standardized over the years now.
Absolutely. My last question to you is that we have witnessed a phenomena, and this phenomena is something like sometimes it happens that you are taking a pre-bronchodilator value and a post-bronchodilator value. So ideally, pre-bronchodilator values, the resistance or the reactance should be higher parameters, and the post-bronchodilator values should be, you can say, like responding to the bronchodilation response. This is an expected response. But sometimes a reverse pattern is seen. That means, like for an example, if you are finding R5 value of somewhere around 8, and then you might find post-bronchodilator, it will have increased to 10, or a X5 value instead of -3, it has become -5. So can you have you encountered these type of problems, and do you really think that is there any explanation behind it?
Laura, I leave the reply to this to you.
Yes, so about the bronchodilation, I think that, well, the first thing is that we need to think about is it's R5 or X5 or AX. It doesn't have to be okay? And the other thing is that I think that the cutoff values are very high. We are working right now in our results after analyzing the bronchodilation in healthy, and well, we are getting that the cutoff points are less, like 27, 29, depending of which variable. But the other thing is that I don't know if it is R5, X5, and AX, the variables that we have to look at for the bronchodilation. I think probably they are perhaps R10 in children's, or the frequency dependence. I mean, not the FRES. Probably that is the variable in small children. I don't know. We need to look for more for this bronchodilation criteria in order to by definitely say that it is positive or is not positive, the bronchodilation.
So one of the idea which I was having in mind, because apart from the allergy specialty, I am also working in intensive care area. So there is a phenomena called as occult PEEP and occult PEEP. So you are aware about that. So I was assuming, or this was my understanding, that probably it is, you can say, like in a severe disease, severe small airway disease, in which the airways are so closed that the PEEP is occult there. And whenever you are using oscillometry as a pre-bronchodilator, the frequency is not going, the sound signals are not able to penetrate that occlusion, and ultimately these smaller areas, because of the occult PEEP, they remain untouched, and that is why their resistance is not detected. And once bronchodilation is given, then they are also opened up, or a little bit is opened up, and ultimately they are also now participating in contributing to the resistance or the reactance. And that could be one of the explanation, because in few of the patients, what I have seen is that when I have found this reverse phenomena to start with, I started them on treatment, and 3 months later, this reverse phenomena has actually got better. It has normalized. So I assume that probably it could be because of some severe obstruction in the smaller airways or the occult PEEP. So we were not able to detect it previously. And then later on, when it improved, then it became normalized. So this was my understanding. So just wanted to share with you. Dr. Vikram, back to you. You are on mute. Dr. Vikram, you are on mute.
Yeah, thank you, Dr. Neeraj, for bringing out this question answer session in between and clarifying the doubts related to lung functions, oscillometry, and the reversibility in between. Now we have our next session, and we are fortunate to have with us Professor Todd Olin from USA. He's a leading expert in the field and who is going to guide us through the nuances of recognizing and managing exercise-induced laryngeal obstructions in clinical practice. Welcome, Professor Todd.
Hi, thank you very much for having me. Can you see my screen and hear me?
Yeah,
Perfect. Okay. Well,
please
yeah,
carry on.
thanks for the invitation to participate. And then I'll give you like a little, I just added a tiny bit on breathing pattern disorder as well, because I think a lot of the patients that we're seeing, which might be very, very different than the patients you're seeing, um, shared sort of this feature in people. And then for background, for those that are watching, my interest relates to shortness of breath during exercise. And I work with a number of different elite athlete populations in the United States. And so hopefully at the end of this, we can walk away with just a couple really simple messages to think through problems when people are not responding to asthma therapy. And what we'll do is we'll focus on the time course of symptom development in relation to exercise and the visual appearance of how people look during exercise or after exercise when they have one of the common problems that we'll see. And so we'll start with a video. And the context of this video is this is a 12-year-old patient. He's not an elite athlete. We knew that he had asthma, and we were doing the test for a different reason. We were doing an exercise test to see if he had another condition because he wasn't apparently responding to asthma therapy by history. He said, you know, hey, I'm taking all the meds and I'm not getting better. And so this is what he looked like on the right at the end of the exercise test. And could you guys hear the video?
Yeah, a little bit. I mean, it goes and comes.
Okay. Yeah, I'm gonna try one thing and change one setting just in case that helps, and then I'll just pick it up again, and hopefully we have slightly better sound. All righty, I'm gonna try that one more time here. And so again, the context is we performed the test because there was not a good response to asthma therapy. All right. How does your breathing feel right now? Does it feel hard or does it feel easy?
Hard.
Hard. Is it like real life hard?
Yes.
Okay. Does the sound any better on that one?
Yeah, better.
Okay, perfect. And so the context of this was this child had an 80% decline in his FEV1 after the exercise test. So in this case, the patient had essentially severe exercise-induced bronchoconstriction. And what I want you to take away from the video is just what does he look like and what does he sound like? And I'll explain the time course of the symptoms. But with asthma, generally speaking, there's not this enormous visual signal. And even though people, when you auscultate them, are wheezing, a lot of times it's hard to detect that from, 2 meters away, 3 meters away. The time course of asthma, and we're going to contrast this with different conditions, is pretty distinct in that if you just are measuring FEV1 every minute or so, and then introduce a 10-minute bout of exercise, say, most people, their airflow will be relatively constant for the first segment of the test, and only right at the end will it drop, and it will continue dropping. And this is why the exercise-induced bronchoconstriction hospital protocols are set so that we're measuring FEV1 for several minutes after exercise to detect any decline. The resolution period is fairly slow. It may be on the order of 15 to 45 minutes. And then interestingly with asthma, and this is really different than almost any other condition that affects the heart or the lungs, if you were to just repeat the exact same exercise stimulus an hour later, a fair number of patients will actually do better from the perspective of airflow decline. And the reason for this is that there's prostaglandins and other mediators generated in response to the high airflow in the first bout of exercise that are still present during the second bout of exercise, and they lessen the magnitude of the airflow decline. So again, asthma, and we're going to contrast this with a few other conditions shortly. It's not really visual, it's not really audible for most people, even when it's fairly severe. And then the time course is generally such that the massive airflow decline, if it occurs, is offset from the peak of exercise. So there'll be the peak, and then later the airflow decline is measured, and then it might be better over time across a day if exercise is repeated. And a lot of, in the absence of a laboratory to be able to test this, a lot of people say, well, hey, let me just gauge a historical response to albuterol and see if the people get better. And I understand why that happens, and I do it myself. And the only thing I would say is I would use a little bit of caution. And so this is a study that was performed by Mike Wexler, who at the time was at Harvard and now works at our institution in Denver. Just a really, really elegant study about the symptomatic response to medicine. And what he did is he had about 40 people, he brought them in knowing that they had asthma. I think to get into the study, you had to have a 20% bronchodilator response or something very, very obvious. And then across 12 visits, he randomized people to different therapeutic regimens in the office. One of them was albuterol, one of them was placebo albuterol, one of them was placebo acupuncture. So I think what they did is they just stuck needles in random places. I've never actually asked them how they did this. And then in the fourth sort of group of therapeutic interventions, they did nothing. They said, hey, we're just going to check your symptoms and spirometry post-intervention. And if you just looked at the airflow decline or the change, or excuse me, airflow increase, the change in FEV1 with these different interventions, people clearly responded more favorably to albuterol, which makes sense, than to placebo albuterol, sham acupuncture, or just no intervention at all. But then when you looked at symptom scores, so this is essentially just asking people how much better they felt, there actually was no difference between the albuterol group, the placebo albuterol group, and the sham acupuncture group. All of those were clearly different than just doing nothing. But I think the moral of the story is you need to use a little bit of caution if you just ask people in clinic if they feel better with albuterol. What we frequently see in our exercise program is a lot of people say that they feel better for about 2 weeks. And then after that, the albuterol stops working, especially in patients that have other conditions. So a lot of times we won't measure a bronchodilator response in clinic. We'll just have a trial at home. They'll respond initially and then it will stop working. And so I'd say we got to do what we got to do, but take history with a bit of caution. So now in the second video, I'm going to show you a woman, really the same story. So in her case, she said, hey, I'm on asthma therapy. I'm not responding. And I want to show you what she looks like. And I'll play it one more time. So this video, this woman has a condition called exercise-induced laryngeal obstruction, or ILO for short. And what's visually different with her is that from several meters away, probably in her case, 20 meters away, you could observe her and say, she's clearly having difficulty breathing. It's clearly noisy. It's clearly obvious. And then I think even from this video, you can appreciate that the time course of the symptom is probably different than asthma, but we'll get into that in a second. But in ILO, there's usually an audible or a visual correlate with most patients, and there's exceptions to every rule. And so what ILO is, for those of you that are not used to working with patients, is that one of the structures in the upper airway, either the cords or the arytenoid/area epiglottic folds. Sometimes the tissue between the arytenoid cartilages will obstruct the airway. And so what I'm going to do is show you a video. 10 seconds are during low intensity exercise, 10 seconds are during high intensity exercise, and just to see the difference between. This is a fairly severe episode, but in this case, I think you could really appreciate what was going on at the glottic level, or the vocal cords themselves, where in contrast to the wide open aperture that was occurring with a heart rate of about 170, when the heart rate increased to close to 190, you could appreciate, 50 to 60% inspiratory obstruction, still with like a little bit of expiratory obstruction as 15-second windows in recovery. What you see if you just take all comers into the lab is that nothing is happening at rest, nothing's happening at 75% max. All of the obstruction is occurring right at max exercise, and it self-resolves really quite quickly. Not everyone has ILO. This is not a normal finding. And if we just delete out from that data set all of the people that just had zeros across the board, well, as you would expect, you get the same signal, but it's just more accentuated. And then even in the most severe patients, if now we only look at essentially the 2s and the 3s, the time course is essentially the same. There's nothing happening at rest. So it really doesn't make sense to only look at somebody at rest. And resting findings have no predictive value as to what's going on at max exercise. Things on average actually open up a little bit from 25 to 75% max. And then everything occurs really above 90% max. And this fourth data point, again, is 60 seconds out. So if you're looking in somebody's upper airway 2 minutes out, the likelihood that you're going to see a problem is really, really slim. And if you're historically working with people that can tell a story, or you get a video of a patient in the field, if their symptoms are largely gone, 1 to 2 minutes after exercise, that really raises suspicion for ILO. What we're doing to look for ILO in our center, it's a challenging test, but we find it useful in that, again, we need to see what's happening during max exercise. And so what we're doing diagnostically to pick this up is we'll place a laryngoscope at rest, and then we'll mount it in place to a helmet. And then currently we're doing these tests on treadmills, but in this outdated video, you can see that the exercise challenge is happening with the laryngoscope moving in real time. And then we're doing this simultaneous to a VO2 max cardiopulmonary exercise test. And so simultaneous to obtaining the laryngoscopy video, we're looking at all different causes of exercise intolerance with the metabolic data. And then therapeutically, what we're doing with these patients is we have a specialty center for this. And so we'll work with patients for several hours over several days to teach them different ways of breathing during high intensity exercise. And we'll use in some of the sessions the images as a learning tool, as biofeedback in the right patient. So in people that think that the visual cue might help their learning, we'll use that to help that learning process. None of the breathing techniques that we use are easy. None of them are really amenable to explaining really quickly on a short virtual meeting. But we use the analogy of this is like learning how to ski, which probably does not translate really well to India. But in Colorado, this is a big part of our culture. And everyone that lives here knows that it takes a little bit of time to learn how to ski. Not years and years, but certainly not 1 or 2 hours. But to be helpful for the audiences around the world, one of the things that we've done at our center is we've worked on the up-to-date page to guide people through a clinic visit. And so if you scan this QR code, I think this pulls up the up-to-date page. And if you scroll down on the left side of the screen over here, there's a section for movies. And the different movies that I've already showed you that pertain to ILO are on this page. And so a lot of times in the clinic, especially if you have somebody show up with a video that characterizes their breathing problem during exercise, you can compare it in the clinic to characteristic ILO videos that are on this page. And so hopefully that's a resource that people can walk away with today. And then finally, there's an entity that we're seeing a lot in patients that have essentially a negative laryngoscopy. So they do the exercise test because they're not responding to asthma therapy in a lot of cases. And then we do the continuous laryngoscopy during exercise and it's negative, which is really frustrating when you're running a center that's trying to learn how to do this. You want to see some positives. And then I know Dr. Gochikoa has probably had this experience where it's very frustrating when you get a negative test. One of the things that we see in a lot of these patients is something called breathing pattern disorder. And the way to pick this up and to kind of consider it is sometimes just observing the breathing of the patient. And so this is a patient that was asked to breathe normally. And what you can see is that first is probably a horrible cue to give somebody because they're probably immediately going to do something that they don't do in real life. But the other thing I want you to appreciate is in people with breathing pattern disorder, there's a lot of thoracic engagement to the breath. So you're looking at them in clinic and they're frequently, maybe every 2 or 3 minutes, taking a big sigh breath. And there's just a lot more thoracic engagement than you would see in patients that are asymptomatic. The time course of the problem is distinct also in that people will come into the clinic and say, I'm out of breath. You're like, what are you talking about? You're just sitting there. You're not doing anything. Your saturation's 98%, your FEV1's 105, or in Z-scores, plus, 0.6 or something like that. And the person will say, no, but I'm still out of breath right now. They'll have shortness of breath out of proportion to sort of conventionally easily obtainable measurements in the clinic all day, maybe worse during exercise. What we see in the exercise lab, if we look at the metabolics with these patients, is that there's a lot of erratic breathing. So in a conventional cardiopulmonary exercise test, the tidal volume and the respiratory rate, as you would expect, increase. And there's a lot of predictability to it in that if at any given point in the test, if the respiratory rate, let's just say is, at this point, like respiratory rate is, 30 and the tidal volume is, in this case, like 2.2 liters, you can pretty much guess that the next breath will be just like that. In people with breathing pattern disorder, let's say at a given point in the test, respiratory rate is 40, tidal volume 0.8. The next breath, you have no idea how fast or how large it will be. And this is a fairly extreme example. The scatter on the patients with breathing pattern disorder isn't always quite so profound. Sometimes it's more pronounced early in the test. Sometimes it's more pronounced late in the test. But this is one of the key findings that we see. The other key finding that we'll look for in our lab, there's a few, but another is just the resting carbon dioxide level. And for us in Denver, so we're 1,600 meters above sea level, our typical end tidal carbon dioxide levels are somewhere in like the 34 to 36 range. We'll call something below 30 abnormal. This number will be less in millimeters of mercury in Mexico City with Dr. Gochikoa. It's going to be more at sea level if you're on the coast of India. And so I'd say you need to figure out what's normal for you. But again, the respiratory variability and the resting carbon dioxide levels can help. The RER will also be helpful if it's highly variable. That points to this. And this is an example of someone that did not have a lot of variability early in the test. These outlier points are inspiratory capacity maneuvers, but the variability really increased late in the test. This is somebody who maybe the variability was more pronounced early in the test and kind of normalized later. So there's different patterns to this for sure. And so if you just had to sort of link these things and create one visual, and this was published by Dr. Hull's group in London. EIB, it tends to not be noisy, tends to not be visual, and the peak of symptoms tends to be offset from the peak of exercise. ILO tends to be noisy and visual and tends to really tightly correlate with the peak of exercise. Breathing pattern disorder is really different in that people will have symptoms all day and maybe they're a little bit worse during exercise. What you see is maybe sigh breathing or a little bit more thoracic engagement in the different breaths. And so again, the take homes are really, if you had to take a picture of one slide that's not graphical like the last one, this is really it. It's asthma, it's really common, but it's not visual. It's kind of slow to trigger and it's variable day to day. ILO is noisy, scary, triggers really at high intensity exercise, and it doesn't clearly respond to medications. Breathing pattern disorder, you'll have symptoms all day in most cases. With that, kind of wanted to wrap this up and thank the hosts for taking my questions as I need to run back to clinic so I don't get in trouble. But thanks again for the opportunity.
Thank you, Professor Todd, for taking out time for our session despite your busy schedule. And we have understood from your talk, EILO is increasingly recognized as a common but underdiagnosed condition that can mimic or coexist with asthma. And differentiating between the two is crucial, as misdiagnosis can lead to inappropriate treatment and ongoing symptoms. So this session from you, Professor Todd, brought a lot of clarity. Thank you very much.
Thanks. Have a great day, guys.
So any questions for him? If they are there, definitely we'll go through.
And if questions come up in the chat, I'm happy if you send them to me. I'm happy to respond by email later today or tomorrow. Yeah. Great.
So one question we have. A vocal cord dysfunction is a very important differential of small airway disease, asthma. How do you diagnose vocal cord dysfunction in your practice? And what is the usual prognosis of such patients?
Yeah, so that's a good question. So, and there's different groups. And so most of my patients have symptoms that are isolated to high intensity exercise. And there's a lot of referral bias here in that in the United States, I'm known for like what we call here sports pulmonology. And so the way that we're diagnosing vocal cord dysfunction, so which we now call sort of the two different versions, the exercise version we'll call ILO for EILO, for exercise-induced laryngeal obstruction. And then in the patients that are triggered by other conditions, we'll call it ILO for inducible laryngeal obstruction, usually triggered by different irritants. And so for the EILO patients, we'll use the continuous laryngoscopy during exercise. And again, it's mostly because our team it's very, very easy for us to do this test. We'll do maybe 1,000 this year. And so I have a lot of infrastructure for this. And I realize how difficult this is to do in other places, and I'm working to solve that. But this is how we do it. The irritant version of the condition of inducible laryngeal obstruction is much more rare. So maybe 100 times less common. Very hard to diagnose because you've got to catch it in relation to the provocative trigger. I do not think that resting laryngoscopy is helpful at all. I don't think that using methacholine is helpful at all. I recognize that people will sometimes have funny little movements of their cords when they're irritated. I don't think that's the disease. What we see when we'll like light cigarettes, we have an exposure chamber, and we'll light cigarettes or use household cleaning products or perfume that, you know, your great-great-grandmother would wear, or we'll, like one time we microwaved fish. That was the worst. And I will essentially take a bandage with perfume on it or a cleaning wipe on it with the laryngoscope already in place using our helmet system, and I will just cover their face and they'll try to breathe through it. And usually what we see when the test is positive is on like maybe the second or third breath. Sometimes it takes several different provocative triggers, but maybe on like the third or fourth breath, immediately there's very high grade obstruction. I don't count the little jiggles. I don't care about that at all. But we'll use the chemical provocative test. But in a lot of patients, you just don't set it off. So I don't think that the sensitivity is very good, but I do think the specificity is very, very high when you set somebody off. So that's how we'll do it. And I realize I'm fortunate in that I have a lot of resources at my disposal to do this, and a team that's has a lot of experience doing it. So
Thank you, Todd, for bringing out the clarity. Thank
So
you very
yeah,
much for
Todd just
bringing
want
your
to
time.
Todd just wanted to say thank you to you. And if you might not be remembering, but in 2018, I shadowed you when I was at National Jewish under Dr. Nathan Rabonevich at that time. And I
yeah,
shadowed you, and I have seen you working with this fantastic job of exercise-induced laryngeal obstruction by myself. And you were just like asking the patient to do the exercise. And I was like wondering that what this particular person is doing. And I can
yeah.
still remember that day. I have still got that video with me. So
Oh, I was trying to remember why I recognized your face.
yes.
So that was totally it. So thanks for
So this
reminding
was
me.
in 2018.
Yeah, great. All righty. I'm sorry I need to run, but thanks for the opportunity, and I'll talk to you
Great.
soon.
Thank you. Thank you.
Thank you. We have a slight change and we'll move to our next session. Now, after diagnosing all these differentials, ruling out differentials and reaching to a diagnosis, while most asthma cases can be effectively managed with our standard therapies, a small but impactful percentage of patients continue to experience frequent symptoms and exacerbations and impaired quality of life despite optimal treatment. And this is what we categorize as severe asthma, a condition that demands a deeper understanding of its underlying mechanisms, phenotypes, and targeted treatment option. To solve our doubts, we are fortunate to have Professor Sara Puliro from Colombia, and she's professor postgraduate in pediatric pulmonology, University of La Sabana, Colombia, and she is pediatric pulmonology specialist from Colombian Pulmonology Foundation. Welcome, Sara.
Thank you so much. I'm really, really grateful being here. Can you tell me if my presentation is on and if you hear me well, please?
Yeah, please
Thank
carry
you.
on.
So, as Dr. Bikram said, I'm a pediatric pulmonologist in Colombia, and we have a certified excellent program of asthma called Asmaire. And I'm really happy to share with you the experiences that we have in our country. I have no conflict of interest. And I thought the best way to talk about severe asthma was through a clinical case because we all relate to that. So I'm going to talk about a 6-year-old boy whose chief complaint was persistent cough and wheezing, not responding to treatment. He had cough, wheezing, and runny nose since the age of 4, no history of serious exacerbations, ICS used with adherence without improvement in high doses, and a medical history of Stevens-Johnson syndrome at age 4, which had not respiratory involvement, no use of supplemental oxygen, and it was related to a skin disease treated with antibiotics. His parents were cousins between them, and his brother has allergic rhinitis. In his physical examination findings, the first time he visited, he had signs of rhinitis, but the rest of the physical exam was normal. And the day of the visit, the patient remained symptomatic. So in the follow-up visits, we heard wheezing in his breath, and he was studied with a chest X-ray, which was normal, and skin prick test positive for dust mites, and spirometry that I will show you next with moderate obstruction and with a significant bronchodilator response. He had 80 eosinophiles and an elevated IgE. So we stepped up treatment with ICSA and LAVA, and we also added Montelukast. He had no improvement, so he was again stepped up with high doses, and he was added with tiotropium in his treatment, but he remained uncontrolled. During his visits, he was also checked by allergology. However, he was found wheezing again, so he was not he couldn't get immunotherapy. And so scores remained with uncontrolled asthma, even if he had adequate adherence and technique to the treatment. We also did a FeNO, which was 18 under treatment, a normal echocardiogram, a chest CT scan. We saw the report that was normal, and a sweat chloride test of 46 millimole, which was normal because of the indirect method. So in this moment, we asked ourselves if we were facing severe asthma, if we were facing difficult to treat asthma, or if this was a case of plus asthma. This was the experiment I was talking you about. So we can see the relationship with FEV1 and FBC, that it was low with an FEV1. Also, there was low with a positive response to bronchodilators. And we then face this current diagnosis with severe uncontrolled allergic asthma and moderate to severe persistent allergic rhinitis. So when we talk about severe asthma, we're talking with patients that control is not achieved or is lost when they're in step 4 or 5 of the GINA guidelines, which means they have a medium dose or high dose of ICAs plus LABA plus another controller, that it could be LTRA or titropin. Our patient had all of this treatment. And so what we did know in this moment, it was that we were facing problematic respiratory symptoms that were not responding to asthma therapy. We asked ourselves once and again if it was not asthma at all, but we knew that we could have overlapping features of asthma, being difficult asthma, but we knew this patient was adherent and he had good technique. We measured that with questionnaires, the pediatric inhaler adherence questionnaire and with the EDIN questionnaire of inhaler technique. We also asked ourselves if it was an asthma plus feature, but we did not find any other comorbidity that would explain this. So under this, we thought we were facing severe therapy-resistant asthma. And we also found, we knew it was severe, but we also wanted to evaluate control. So we asked ourselves how was this patient exacerbating his asthma, but he had no use of systemic corticosteroids. He didn't require any hospitalization or emergency room visit. He did have a low GINA score, which marked uncontrolled, same ACT, and his lung function tests were moderately impaired, as I showed you before. So we were facing truly an uncontrolled severe asthma assessment, but again, is it asthma? We found differential diagnosis, no bronchiectasis on CT, normal echocardiogram that ruled out a heart disease, and again, we ruled out CF. Then we looked for our causes of poor control with adherent and inhalation technique, with Tobacco on our allergen exposure, which were negative, and there were no important coexisting conditions. He only had rhinitis, but it was under treatment. So in this step, we should be phenotyping and personalizing his treatment. He had a high T2 asthma because he had elevated IgE and a sensitization with clinical relevance, but he did not have elevated eosinophil count or FeNO. And this is important because severe asthma, it counts for a lot of people. You may know this much better than I, but the prevalence of severe asthma in children in India can be very varied between regions, but it can count out even to 18%. The most recent study I found was this systematic review and meta-analysis from 2022, which found a pool prevalence of childhood asthma of almost 8%. In my country, global prevalence is of 12%, but it can be as high as 19% in children under 5. So that would mean severe asthma can account for more than 200,000 people in my country. which it would be a lot more in yours. This is what happened in my program last year. So we were looking how many of the patients could have a good control, which for our program, the goal is more than 60%. And we achieved that goal, but then analyzed what were the causes, why did not all patients achieve improvement or maintenance of control, and the number one cause was comorbidities. These were the top 5 comorbidities in our population, being sleep apnea, neuropsychiatric diseases, food allergy, reflux, and allergic rhinitis, the most common. They also found infection as the second most common cause of losing control, especially in the first trimester, which is a rain season. And this was really coherent with what we found in the most prevalent circulation of viruses, especially rhinovirus. And in the third place was poor adherence, which is really, really important worldwide. In our case, we measured adherence by questionnaires, and we found that up to 41% of non-adherent causes were related to difficult access to asthma medication, with which I think you can also relate to, and which is this year's World Asthma theme. And the first cause was forgetfulness, which is also like worldwide a cause of non-adherence. And we also measured technique with eating questionnaire, and we found that in teenagers, MDI and the use of spacers were the most difficult technique teens had, especially in exhalation. And in severe asthma, when we just ruled out these all other causes of losing control, we made the medical boards for these patients to see if they were candidates for biologic therapy. And this is our study. We hope it can be published soon, which is risk factors for poor control in a pediatric population with severe asthma. And our population had good adherence. We had, even in control and our control patients, more than 60% of adherence. Most uncontrolled patients had a T2 high phenotype. The most common comorbidity was allergic rhinitis, but it had no difference between control and uncontrolled patients. But sleep apnea was more frequent in patients not which were uncontrolled. We also assessed lung function, and most of our patients had normal lung function, but we did find a difference in FIV1 reversibility or bronchodilator response, even though it wasn't clinically important. In both cases, it was under 10%. In uncontrolled patients, it was higher. And this is an encouraging data because most of our patients showed good adherence, which is not what commonly happens in the world. And we think an asthma program can make that happen. And 90% had correct inhaler technique. But we have serious limitation on our healthcare system to guarantee the timely delivery of medications. Sleep apnea had the strongest association with poor asthma control. So we need a multidisciplinary approach to treat severe asthma. And as happens in the world, parents admit occasional forgetfulness or discontinuing medications when symptoms improve. And having lower adherence is associated with worse clinical outcomes, such as severe exacerbation and lower quality of life. So returning to our patient, would he be a candidate for biologic management, or he would require more studies or alternative treatments? And the APIC study, which included 700 children in 9 centers of the USA, made clusters of those patients who would benefit the most of biologic therapies. And a patient was in cluster E with severe uncontrolled asthma, very high burden of allergy and inflammation. So he would be an ideal candidate for anti-Th2 biologic therapy. But which therapy would be best for him? So in teens and adults, we have more information about exacerbation reduction, which is mostly seen in omalizumab, in dupilumab, and in benralizumab, but there's little studies on the effect of biologic therapy on FEV1, especially in teens and in children. But our patient was younger than 11 years. So in this case, we had exacerbation reduction both in omalizumab and dupilumab, but some more effect over FEV1 using dupilumab. So as this is a severe asthma talk, so I'm going to talk about some of the most important biologic studies. And in dupilumab, this is the Voyage study, which included children from 6 to 11 years old. And it reduced exacerbations in T2 high phenotype in almost 60% of them. And it was greater effect if the children had more than 300 eosinophils. It also improved lung function, as we were talking before, and it also significantly decreased FeNO, EGI, and TARC. Quest study included teens and adults. It also reduced the risk of severe exacerbation in T2 high phenotype, and it was greater with higher levels of eosinophils, but also of FeNO. And in adolescents, the lung function improved similar to adults, but it was variable between the dose. It was better with 200 milligrams every 2 weeks. And biomarkers that best predicted response were eosinophils, FeNO, or over 20 in children. Mepolizumab blocks IL-5 and demonstrated also a 53% reduction in severe exacerbations in adults and teens, but it has a very modest increase in FEV1 and allows the reducing of oral corticosteroids, which is less common in children. And in teens, results were comparable to adults, but it had a wider confidence interval because of the small numbers by patients studies. So that's why MEPITS-2 study came, which was realized in Euro children from 6 to 17 years old, and it reduced severe exacerbation at a lower level by 27%, did not significantly improve lung function or asthma severity score, but I thought it was really interesting that they identified nasal genetic profiles to predict the risk of exacerbation, and I think this could open new avenues for personalized biomarkers in children and in adults as well. And lastly, tezepelumab with Navigator study, TSLP blocks high T2 and low T2 phenotypes. It had a reduction of exacerbation of 56% regardless of the baseline biomarkers levels, but it was greater if the patient had more than 450 eosinophils. It also improved FEV1 and asthma control and quality of life compared to placebo, and decreased levels of eosinophils, FeNO, and total IgE. In adolescents, 82, it showed a reduction in exacerbations with RR of 70, but with wide confidence intervals. And I think that what is most useful of this biologic treatment is that it does not require demonstrating a phenotype, but we have no studies that have been yet finalized in children under 12 years of age. This is the Navigator study. So coming back to our patient, we have allergic asthma, but with a low eosinophil count, with a low FeNO. So if we follow this algorithm, he would be a candidate for omalizumab. And in that time in our country, it was the only biologic treatment we had available for children. So we started omalizumab in this patient. This patient persisted with a wet cough, and he persisted with obstructive impairment of pulmonary function test. We can see how the relationship remained low and FEV1 remained low, now with no response to bronchodilator. And when we saw how FEV1 was in the follow-up, it became every time lower when we looked the standard deviation. So we again ruled out other pathologies. We repeated an echocardiogram, which was normal, no evidence of indirect pulmonary hypertension. Another sweat chloride test, which was normal, immunoglobulin test, which was normal, and then we made again a chest CT scan. But before I show you the scan, I wanted to show you how in severe asthma, it's really common that in children there will be no functional impairment, but it is also very common that children under treatment will improve their level of FEV1 and decrease the response to bronchodilators. As you can see here, it's most of patients were not impaired of their lung function, and so it was really shocking that our patient was going every time worse. So I don't know if you can see this as well as we saw it on the X-ray screen, but this has a mosaic pattern with a mucus plugging and tree bag and also some bronchiectasis. So we decided to focus this patient as a bronchiectasis patient, but we had ruled out cystic fibrosis, we had ruled out primary or acquired immunodeficiency, which with more studies that I didn't bring up, but we also studied T cells and antibody response. We ruled out PCD with genetic studies. We made a bronchoalveolar lavage and we ruled out tuberculosis, protracted bacterial bronchitis. We also ruled out allergic bronchopulmonary aspergillosis. And so we still had asthma as an option, but we also had Stevens-Johnson syndrome associated. This is rare because he had no respiratory symptoms, but this patient began with respiratory symptoms months after he had Stevens-Johnson's. So just to tell you the outcomes of this patient, we still think he has asthma, but we think it's an asthma class. And we also think his prognosis is not very good. So we maintain the biologic therapy because when he was receiving it, he improved his lung function. And when he stopped receiving it, it went down. So we think he has a little bit of benefit, but we also had some rehab for this patient. We are treating his bronchiectasis, and we think probably he will need lung transplant in the future. So sometimes our reality in severe asthma surpasses fiction. We have to assess, adjust, and review the algorithm every time our patient does not meet the goals. We should make every attempt to differentiate between difficult to treat asthma, asthma plus, and severe asthma whenever is possible, or at least to find the most predominant characteristic that affects control. In severe asthma, phenotyping is important to make the best decision in treatment, but the decision to use biological treatment, it depends on patient's profile, on phenotype, on goals of the patient, but also on the availability on each of our countries. And biological management should always be accompanied by adequate adherent inhaled therapy with good technique. Thank you so much.
Thank you, Sarah, for making this complicated topic simple with a beautiful case-based approach. Highly appreciate the way you explained in detail management with biologicals in step 5 of GINA guidelines. Thank you. Thank you very much.
You're very welcome.
Yeah, so shall we take questions or we shall go ahead with Dr. Neeraj's talk and then at last we take question answers? 10-15 minutes
Yes,
more.
no problem.
So let us continue with our discussion. As Sarah mentioned, that in severe asthma, phenotype is very much important. And today is the era of precision medicine. It becomes important to recognize and tailor our management as per asthma phenotype. And FeNO has emerged as a valuable non-invasive biomarker that reflects eosinophilic airway inflammation. Yet, despite its growing use and clinical value, it remains underutilized in many settings, particularly in our country, partly due to unfamiliarity with its interpretation and integration into routine practice. So, today's session aims to bridge the gap by providing clarity on the science, behind FeNO and its practical applications. So we have with us our own Dr. Neeraj Gupta, who is chairperson of IEP Allergy chapter. Welcome, Dr. Neeraj.
Thank you, Dr. Vikram. And I think a beautiful talk, very beautiful talk by Sarah. Though every speaker has done really wonderful job, but Sarah has really made the way for the next talk about FeNO. So I would like to go about a little bit more deep inside the FeNO pathophysiology so that everybody understands that what we are talking about. FeNO is one tool which is very much underutilized, at least in this part of the world. So that is why I am trying to go from the basic and then I will go that where it should be applicable, especially in this part of the world. So first of all, what is FeNO? FeNO is basically fractional excretion of nitric oxide. And what is nitric oxide? So nitric oxide is a gaseous signal molecule, which is actually having a biological role, a physiological role inside our body. So it is an essential biological mediator, which actually has several different vital roles, especially in maintaining the airway function. So FeNO is basically a biomarker, which is widely used to assess the airway inflammation, particularly in allergic disorders like asthma or rhinitis, and its level often correlate with the severity of eosinophilic inflammation, which is considered to be a key component of Th2 pathway or the allergic responses. And especially in the pediatric age group, the Th2 pathway is predominantly covered up by eosinophilic inflammation. So it is more related to the nitric oxide production or estimation of FeNO, which becomes essential and useful. So it's a valuable tool in both diagnosing and monitoring these conditions due to its non-invasive nature and its ability to reflect underlying inflammatory process. Coming to a little bit about the biological functions of nitric oxide. So in the brain itself and as well as in the pulmonary circulation, it actually helps us in the vasodilatation. And because of the vasodilatation, it ensures optimal oxygen exchange and respiratory function. Whereas in the brain, it acts as a very important neurotransmitter and which actually helps in maintaining the airway tone, and thus it regulates the airway resistance. Now we come to the area of interest for today's webinar, which is airway hyperresponsiveness. So in physiological doses, whenever it is produced physiologically, then it acts as a protective mediator and it prevents the airway hyperresponsiveness by its bronchodilator effect. How this nitric oxide is produced? So this nitric oxide is basically produced in lungs by nitric oxide synthase enzyme, which is also called as NOS. And this NOS can be present in three major isoforms. And L-arginine is the main substrate through which nitric oxide synthesis happens. So L-arginine is basically metabolized by nitric oxide synthase and ultimately it produces nitric oxide. Now there is another substance which is called as ADMA. So ADMA stands for asymmetric dimethyl arginine. Now what it does is that it has a competitive inhibitor action on nitric oxide synthase to L-arginine. So if because of certain reasons this ADMA is present in higher amount, then it gets attached to nitric oxide synthase or NOS, and ultimately the L-arginine concentration can increase. So these are the three type of, you can say like nitric oxide synthase which are present in the body. N stands for neuronal, E stands for endothelial. So this N nitric oxide synthase and endothelial nitric oxide synthase, they combinedly are together called as constitutional nitric oxide synthase or C nitric oxide synthase. The pathophysiology or the pathophysiological mechanism happens through inducible nitric oxide synthase, which is specially induced in response to inflammation, especially to Th2 type of inflammation. So the interleukins like IL-4, IL-5 and IL-13, they actually trigger this inducible nitric oxide synthase, and this inducible nitric oxide synthase ultimately metabolizes arginine, L-arginine, and produces large amounts of nitric oxide. The nitric oxide, when it is produced in the physiological amount, is usually good. It is protective. But when it is produced in the large amount, then at that time it produces pathological effects, which I will come to you soon. So inducible nitric oxide activity is significantly upregulated, especially in case of type Th2 inflammation like allergic asthma and rhinitis. And thus it comes in the exhalation, which is exhaled nitric oxide, also the principle of FeNO, and which serves as an indirect marker for upregulation of airway inflammation, particularly eosinophilic inflammation. So if we just see very carefully this diagram, so this L-arginine is the baseline substrate. And through this L-arginine, now in the constitutional nitric oxide synthase, which is the physiological condition, produced nitric oxide is actually helpful. It produces certain axial nitric oxide, and it is useful in the physiological functions, maintaining the bronchial tone, bronchial dilatation, bronchial protection, anti-inflammatory effect. But either in the presence of ADMA, when this pathway is blocked because of the competitive inhibition of inducible nitric oxide, or in the presence of Th2 cytokines like IL-4, interferon gamma, TNF-alpha, so all these produce increased inducible nitric oxide synthase. And ultimately, the nitric oxide production exponentially increases. When it increases exponentially, then at that time, now the host defense is breached. And at that time, the cell damage happens because of the nitrative stress. Because the nitrogen radicals are so high in number now that it produces nitrative stress, and which causes cell damage, DNA, mitochondrial and protein dysfunction, and airway hyperresponsiveness. So I was mentioning that in low concentration of nitric oxide, it is playing physiological role, maintaining normal respiratory function, maintaining normal ciliary movement also, and also helps in clearance of the mucus and pathogens. But in high concentration, it actually is pathological and ultimately causes airway remodeling, chronic inflammation, and bronchial hyperresponsiveness. So when I was mentioning about nitric oxide in higher content, so what happens? That nitric oxide in higher content get attached with the superoxide anion and ultimately produces some reactive nitrogen species, also called as peroxynitrite. Now, this peroxynitrite and other reactive nitrogen species, they actually causes oxidative stress, nitrative stress, and produces cellular damage, airway remodeling, and worsening of airway responsiveness. And simultaneously, many times it happens that the arginine itself, when accumulated, then it also causes excessive airway inflammation by its products, impaired nitric oxide synthase, and ultimately produces hyperresponsiveness. So the same thing, which is the phenomena with ADMA, that stress. So this was the pathophysiology of FeNO production or the nitric oxide production. Now, what is the principle behind estimation of this FeNO? So there are two types of principle. One is called a spectroscopic method, also based upon chemiluminescence. Other is called as electroanalytic method, which is based upon electrochemical sensor. Let's see one by one. So first is chemiluminescence or the spectroscopic method. Now this spectroscopic method is considered to be as the gold standard method for FeNO measurement, right? So this method is basically using a significant amount of ozone, and then a chemical reaction is happening with the nitric oxide produced to produces a fluorescent radiation, and the intensity of the emitted light is directly proportional to the FeNO measurement. So it is very sensitive, it is very accurate, but the problem is that it actually requires, you can say, like higher degrees of standardization. It actually requires, it is more costly, and it can only be done in the research tools. So commonly in the portable device, what we are using is electrochemical sensor. So this electrochemical sensor, it can be used as a point of care testing and home monitoring for FeNO levels. So this electrochemical signal is having, you can say, like a little lower FeNO values as compared to the gold standard, which is the chemiluminescence method. But if suppose if a patient is coming to us, you are doing the FeNO value, you are doing some intervention and then repeating the FeNO value after some time, then this does the trick for majority of the patients, because it is providing you point of care testing. It is also providing you a cost-effective testing. So there are several methods of FeNO measurement. It could be online method or offline method. So commonly we use the online method. In the online technique, it is the real-time estimation which is happening when the person is breathing in the machine. Whereas in the offline FeNO method, it is basically the person is breathing in a reservoir, and then the reservoir, we are just trying to measure the static amount of FeNO in the reservoir, which is a little inferior technique. So this is basically the mechanism by which FeNO estimation happens. So the person is breathing from here, and then the flow sensor is coming up, and ultimately all these wall resistance is happening, and then the FeNO values are based upon the plateau. So this plateau is reflected. This plateau is reflected as a FeNO value. This plateau is reflected, and it measures the plateau that whatever the value is. So the one more requirement is whenever you are doing FeNO, so there has to be a sufficient exhalation duration. It is considered that under 12 years of age, it should be at least 4 seconds, whereas it should be at least 6 seconds for an adolescent and adult patients. Now, there are several factors which can actually affect physiological values of FeNO. Like in pediatric age group, the FeNO values are little lesser as compared to adult because the nitric oxide production increases as with the age, as with the development of the immune responses. Males produce a little higher FeNO levels physiologically as compared to females. Ethnicity, Chinese people have a little higher FeNO values as compared to rest of the other groups. During hormonal fluctuations, especially during the menstrual cycle, even the FeNO values can be altered because of the estrogen and the progesterone level variations. Then during pregnancy, the FeNO levels can vary. Similarly, in other conditions like severe obstruction, COPD, even there is increased nitric oxide production which can happen. And then if you have done spirometry or probably other type of pulmonary function testing which have required a forceful breathing, then at that time you are forcefully washing out nitric oxide. So ideally, FeNO should be done first and then other pulmonary function tests should be done. If your patient is on inhaled steroid, then at that particular time also it is likely that the FeNO levels will be suppressed. If the patient is having some respiratory tract infection, then there could be increased inflammation and increased FeNO levels. In chronic respiratory diseases like cystic fibrosis, bronchiectasis, PCD, COPD, the FeNO levels can be lower because of the impaired ciliary dysfunction. Obesity can increase FeNO levels because of the systemic inflammation which it produces. Then smaller airways produces lower FeNO levels and ultimately as compared to larger airways. So it all depends upon that which size of children or which airway we are talking about, and then hypoxia decreases FeNO levels. Similarly, in smoking, it can also reduce FeNO levels. Alcohol can also reduce FeNO levels. So this is the table which is actually summarizing that there are certain factors or several factors which can actually cause physiological increase in FeNO level and several factors which can cause physiological decrease in FeNO levels. So we need to take all these factors in cognizance whenever we are talking about FeNO. These are the reference values which have been prescribed, especially for the adults and the pediatric age group. In adults, it is like the range is considered to be 25 to 50 is considered to be okay range. Anything which is more than 50 is considered to be high FeNO, whereas in pediatric age group in children, it is 20 to 35, which is considered. One more important difference is whenever you're talking about like the difference between two FeNO values, the first value and the second value. So a variation of 20% or more, either increase or decrease from the baseline, is significant in adults, whereas in pediatric age group, it is considered as an absolute value change of at least 10 parts per billion is considered to be significant. So now coming to why I am talking about so much about FeNO, because after understanding FeNO, can we use this in our management in clinical practice? So let us see. FeNO can actually enhance the personalized care. So when we should do FeNO, ideally FeNO should be done as a baseline to know that, okay, whether it is eosinophilic inflammation or not. If it is suggestive of eosinophilic inflammation, then the treatment should be initiated like ICS or INCS, depending upon which FeNO levels you have taken, whether it is the nasal FeNO or the bronchial FeNO. And then you should also do the follow-up monitoring just to see whether the treatment is effective or not, whether you need to adjust the doses of inhaled corticosteroid, or probably you have to think about other alternatives like biologics, as Sarah has just mentioned about Th2, biologics like omalizumab and others. So a significant reduction in FeNO during the treatment like corticosteroids or even allergen immunotherapy, that actually tells you that, okay, these measures are effective. So this is an objective measurement or objective effectivity of allergen immunotherapy or inhaled corticosteroid. You can use it like that. Persistent high FeNO, you have to probably think about adjusting ICS doses or biologic therapies. So FeNO-guided management is actually helpful, and FeNO is predictor of airway inflammation, in which eosinophilic airway inflammation, so it is definitely have a predictive value. FeNO and steroid stewardship, yes, definitely. So by monitoring the FeNO levels, you can actually go up and simultaneously go down with the steroids or inhaled corticosteroids, which in the absence of FeNO, then at that particular time, we are just doing a blind clinical symptom-based steroid up and down. So steroid stewardship, we need to really think about that. And FeNO for monitoring asthma control, yes, definitely, it can help us in monitoring asthma control. So in allergic rhinitis, definitely, it can also help in monitoring allergic rhinitis, like in asthma. So it can actually tell us about eosinophilic inflammation from non-eosinophilic inflammation in patients with allergic rhinitis symptoms. I have told you about the cutoff values. So I will be just now quickly discussing two cases before I stop my presentation. So case one is a 6-year-old boy with long-standing history of asthma who was diagnosed at the age of 3. His asthma is characterized by persistent symptoms, including wheezing, cough, shortness of breath, particularly at night and during physical activity. He is also known to have allergic rhinitis with seasonal exhibitions, particularly in spring and fall. On asthma control, despite being on inhaled steroids, bronchodilators, his asthma remains poorly controlled with frequent nighttime awakening and frequent school absences because of wheezing and persistent coughing. His quality of life is significantly affected. Allergen sensation is known to have dust mite sensitized, and which has been confirmed by allergic testing. And then the comorbidities are there like allergic rhinitis, and he's overweight, 90 percentile. His initial FeNO levels were 80 parts per billion. Target FeNO range, targeting like less than 20, or elevated FeNO was considered more than 35 because he's more than, in case of 12 years of age. But for this age, in case of less than 12 years of age, suggestive of airway inflammation. So follow-up FeNO in this particular child, despite increasing the ICS dosing and daily Montelukast, was just 75. So 80 to 75. That means we wanted an absolute change of at least 10, but it has not shown even that also. So there is something which is happening. What we have done, we have probably titrated the pharmacological therapy, added a plaba, oral corticosteroids were added, managed allergic rhinitis also, managed obesity and other factors also, avoided triggers, antihistamines, and then we did the regular FeNO monitoring, and ultimately a target of more than 20% or absolute decrease of 10 parts per billion from the baseline was the goal. And we also executed some lifestyle modifications for weight management and physical activity. And then in the long-term management, we also executed immunotherapy in this particular child for dust mite specific immunotherapy. And then later on, we have to also go for biologic therapy in this particular child, as had already been discussed. So what I wanted to say that FeNO is a very useful point of care testing, directly indicate Th2 or the eosinophilic type of inflammation. It can actually help us in not only escalating, even de-escalating our management. This is the second case. Miss S, a 12-year-old girl with a history of persistent allergic rhinitis for past 3 years, characterized by typical rhinitis symptoms, particularly during spring and fall, allergic to mites, pollens, and pet dander. And then, despite her symptoms being well controlled with intranasal steroids and antihistamines, her nasal congestion worsens during high pollen season, and she is also having postnasal drip and occasional coughing at night. Sarah denies any eczema symptoms. There is no wheezing, no shortness of breath, no exercise-induced symptoms. There is past history of eczema, but nothing suggestive of eczema. No history of hospitalization or emergency room visits because of respiratory issues. And Sarah's FeNO levels and nasal FeNO levels have been done. So these are the nasal FeNO levels and oral FeNO levels. Suppose in this condition, if we have not done nasal FeNO, we have just done bronchial FeNO, which is 85, we would have easily labeled it like, oh, this particular child is probably having type 2 inflammation, eosinophilic inflammation going in the airways. But here, the nasal FeNO is 550, which is very high. So when nasal FeNO is so high, then at that time, some dilutional effect or some, you can say like contribution of nasal FeNO can also be captured when you are capturing actually the bronchial FeNO. So this 85 parts per billion could be contributed by so high nasal FeNO because of allergic rhinitis. In this particular child, spirometry as well as oscillometry were absolutely normal. So we have just treated this child with only nasal medications and no inhaled corticosteroids were given. So high FeNO can still occur, bronchial FeNO can still occur in patients with allergic rhinitis due to some amount of eosinophilic component of inflammation in the airways. Although asthma is typically associated with lower airway inflammation, but persistent allergic rhinitis can also cause mild inflammation and cause elevated FeNO levels. So what I wanted to say that if in a given case, you are doing bronchial FeNO and you are able to find some values of 60, 70, you need to really think about with the consistency with the clinical picture, with your lung function testing, and then only you take a decision rather than just going very dogmatic, oh, this is more than 35, this is more than 50. So it is probably the indication of starting inhaled corticosteroid. So this particular child has actually been very well managed with only nasal management, didn't require any inhaled corticosteroid. So take home points. Nitric oxide is a physiological mediator required for airways health. Inducible nitric oxide synthase production is stimulated by Th2 inflammation. Axial nitric oxide level is a useful biological marker for eosinophilic inflammation, and serial monitoring of FeNO values gives better understanding of pathophysiology and management efficacy rather than only one snapshot of FeNO value. So with this, I will stop my presentation and happy to take any questions.
Thank you, Neeraj, for sailing us through the basics of this underutilized FeNO test. Excellently, you integrated its usage in the algorithm of asthma management. and hope this will get incorporated in widely in our practice soon. Thank you. I thanks all the speakers for those enlightening presentation. We'll now move on to the question and answer sessions. We'll try to take as many questions as the time permits. We have 10 minutes more, and we have few questions. So I'll direct few questions to our speakers with the. So So my first question to uh, Professor Laura, bronchodilator is sometimes not seen on spirometry, but changes in the FEF 2575 is seen after bronchodilator trial on spirometry. Any significance of this?
Yes, the problem with the FEF 2575 is that that measurement is very variable because it's very FEBC dependent. So it depends how the patient do the maneuver in order to get that. That's why we don't use that variable for bronchodilation. Well, for anything.
Yeah, thank you very much. So my question is to Ilmaz. Now you mentioned about the small airway disease. Now, any specific inhalational corticosteroids would you prefer to be used in small airway disease?
Sometimes fine particles have been suggested, but there is not the evidence is not enough to say that, because not only the diameter but also the technique used and the flow rate influences where the particles reach. But if we are observing a small airway phenotype, then we might choose to try fine particle inhaled steroid.
Thank you. And extending with that, any change in the inhalational devices can be made to have the maximum delivery of the drug to the smaller airway.
Not enough evidence for that to state that, unfortunately.
Yeah, thank you very much. Now, next question is to Professor Todd, but he is not here. Any one of you can take this. Can spirometry or impulse oscillometry provide any indication of EILO? Any one
No,
of you can take. Yeah.
No, I don't think so, because as Dr. Todd said, you need that symptom starts when the individual start to make the exercise. So it's very important that you do the complete test, but with the exercise.
Yeah, thank
Like
you
the
very much.
name is now, exercise-induced larynx obstruction. So this is because it's induced by the exercise.
Yeah, thank you very much. Next question is to Dr. Neeraj. Would you consider FeNO monitoring in all persistent asthma?
So if you ask my practice, I am actually using FeNO very often. And in my unit, I am using very much use of even nasal FeNO also. Many times patients come to me with overlapping symptoms in which they are just coming with some post-nasal drip, some cough, and you're really not sure that whether it is purely because of asthma or small airway asthma, or it is coming through the nose. Then at that time, rather than treating them blindly, what I do is that I usually do oscillometry and I do the nasal FeNO. So suppose if the oscillometry is having some uh, airway obstruction, small airway obstruction, and nasal FeNO is also high, then I treat both of them. If suppose oscillometry is absolutely clear, there is nothing is there, and only nasal FeNO is showing higher values, then I treat only nose and I just follow up the patient. I do not give them inhaled corticosteroid.
Great. So treating comorbidities become easy if we use both these tests simultaneously. So you have already answered the next question about allergic rhinitis monitoring. Any difference in the opinion from the international faculties over here on the usage of FeNO and regular monitoring? Laura, you can answer that. Any what is your practice of using FeNO?
Well, we use a FeNO for, of course, for asthma follow-up, but also for nasal dyskinesia. And right now we are starting to work with the alveolar FeNO. I think that is, at least there are some cutoff points for that. And I think that will help also because there are some evidence that it is still high before the typical FeNO or the mechanical lung function test, they become to normal, but the alveolar FeNO is still high. And for children, we are also starting to work in this offline FeNO. So these small children that cannot have the flow at 50, we can do it offline and see if it is high or no. That the highest prevalence is in those less than 5 years old, and those are the ones that sometimes cannot do the test. So that's what we are doing with the FeNO here.
Thank you very much. What is your experience about FeNO, Sarah?
We use it, of course, in type 2 high phenotype, and we use it for diagnosis and for follow-up. And it's very important in the adherence evaluation because sometimes questionnaires may seem like patients do have good adherence, but when we measure up FeNO, we can find there are still some issues, and we're facing really a difficult to treat asthma and not a real severe treatment-resistant asthma.
Yeah, that's great. So before stepping up the treatment, we can check the adherence from the FeNO also. May I ask Ilmaz also about your experience?
In Turkey, actually, FeNO measurements are not covered by the social security. It's very expensive, so it's very expensive for the patients to cover. So unfortunately, we can't use it for routine patient monitoring, but for patient only for research purposes. So it's not in routine use in Turkey right now.
Thank you. Thank you for your comments. Any more questions?
Yes, I want to ask. I read that in the last clinical case that you measured the nasal FeNO. So you use the nasal FeNO as a follow-up test for just for allergic rhinitis. In that case, what are the minimal clinical changes that you are expected to see in those patients to see if the treatment is better or not?
So usually during follow-up, what we are using is we are just going with the clinical symptoms only. And majority of the times, the patients are getting benefited in the clinical symptoms. And whenever appropriate, we are also starting with allergen immunotherapy. So patients are anyway getting benefited. But in persistent cases, if it is not helpful, then at that particular time, yes, we once again look at the FeNO values, nasal FeNO values, but not routinely. But routinely in the initial time, I usually do in all allergic rhinitis patients, but not for a routine monitoring for every patient. Only in the severe persistent cases I do in a follow-up patient.
Thank you, Dr. Neeraj. So we have finished off with the questions. I think it's the time to end our session. And on behalf of the IEP Allergy and Applied Immunology chapter, I thank all our esteemed speakers for their exceptional contributions today. We are deeply grateful for your time and knowledge. A warm thanks to all the participants for joining. Let us take forward this learning to improve asthma care in our country for the betterment of our patients and community. Wishing everyone a healthy and inspired journey ahead. Thank you and good night, everyone.
Thank you. Thank you.
Thank you. Good night.
Thank you.